Well, hello everyone. Good afternoon. And gosh, it's nice to see everyone at least virtually at this NAMI annual conference. I had the opportunity and the privilege to participate in this conference, this annual conference, for many years, and really enjoy it quite a bit. And I'm glad to be here with all of you guys. I'm actually a professor of psychiatry and also an internist at University of California, Irvine in Orange County, and so I'm happy to be with all you guys. Today, the plan of attack is to talk about depression and anxiety, and I'm going to go over some helpful pointers on, gosh, how do you diagnose depression? Maybe how can you prevent it? What are some treatment options? I also have a bunch of questions that many of you have submitted previously, and I'm going to go and address those as well during the talk. Feel free to send some questions live, and I'll try and address those in real time as well. But really want this to be sort of an interactive experience where we can address some real questions kind of in a very straightforward way, and go from there. But for today, I want to know what you guys want to know. So again, if you feel free to use the chat feature, throw in any questions if you want. We're going to talk about what is depression. We'll also talk a little bit about anxiety, and then prevention and treatment. But before I go on, I want to address one of the questions that came through earlier in the week, and the question was this: do you think we're going to have a pandemic in depression and anxiety? And the answer is, I think we're already there. I have so many patients that are struggling, just really struggling with depression and anxiety during this pandemic. And there's a lot of components. There's fear, there's concern, there's the unknown, there's economic stuff, there's political stuff. I mean, there's a lot happening right now. And so we're really seeing pretty much in all age groups. In particular, I'm seeing a dramatic increase in folks who are in their 20s and 30s struggling right now. Even with a sense of identity, many people are losing their jobs. So I would suggest that we are dealing now with a psychiatric pandemic. And that's why I think this talk is so important. And hopefully you guys will get something out of it. I want to start off by saying that psychiatrists, psychologists, social workers are not the folks delivering the large majority of care in behavioral health in the state and in this country. In fact, it's interesting. It's primary care providers who are delivering most of this care, about 60% or so. Unfortunately, a big chunk of people just aren't getting any care at all from a mental health provider or a primary care provider. And those are the folks we're trying to get to, actually, and try and help out as much as we can. But what do you want to know about depression? I mean, here's some things that I think are pretty important. Depression, it's common, and it's treatable, it's addressable. For those two reasons, we actually try and screen for depression. We try and pick up depression earlier, prevent depression, particularly in the primary care setting. But it's very common, and about 20% of people in their lifetime will at least have one discrete episode. Many people who have one discrete episode in their life will have a second episode. The chance of having a second episode is about 50%. And if you have a second episode in life, the chance of having a third episode is about 85% chance. So the more depressive episodes you have in your lifetime, the more likely you'll have more, unless you prevent it, you treat it, you address it. It is the leading cause of disability in the United States among those aged 15 to 44. It's the second cause of disability worldwide. Unfortunately, we kind of miss the diagnosis, particularly in the primary care setting, about half the time. But it can be prevented, it can be treated, and so that's some of the stuff we're going to talk about today. Now, the thing is, the majority of patients with depression won't spontaneously recover within 4 to 6 months. However, they often will spontaneously recover within a year to a year and a half, but that's a long time to suffer from depression. A lack of recovery is associated with more episodes and even what we call somatic symptoms, or having pain-related issues that are connected to someone's mood. So a lot of times patients will have fibromyalgia, tight pain, what we call soft tissue or muscular pain that can be found or with depression. So it's important to partner with your provider, right? Partner with your provider. Work as a team, in which case you're an integral part of that team, right? The most important part of that team. And I think that's probably one of the most important things that I'm going to say today is to partner with your provider. You know, a lot of folks out there will just say, well, you know, I'm just going to do what my doc says, right? And that's okay to a certain degree, I suppose, but really should be a partnership. And it should be a situation where if you have questions about a medication or diagnosis, it's good to ask. It's good to ask. And it's good to do some of your own homework and then follow up with questions and or concerns if you have them. Make sure you know what's going on, how those medications work. Are there any side effects? Very important to kind of look at that. It's very important, in fact. So partnering with your provider is going to be important. Education is prevention. You know, my wife says in these talks, I should put a picture of myself here. And so she was joking. She sent this cartoon to me. This is this poor guy trying to get into this building. He's pushing, and the sign here says pull. But I think education is really so important. And that's part of what we're doing today is we're going to educate you guys on some basics of, you know, psychiatry, if you will. Psychiatry 101. I do a lot of training for primary care providers nationwide and teaching them how to pick up early stages of emotional angst, you know, emotional difficulties or problems. Oftentimes they're missed. In fact, we find that, for example, people who kill themselves, who commit suicide, and those numbers are increasing significantly per CDC data, unfortunately, that stuff's missed. About 50% of people who actually commit suicide have seen their primary care provider within 1 month of committing suicide. 1 month. So it's a good opportunity for us, for PCPs, to learn how to prevent this and come up with early recognition of depression. So I'll share with you guys one of the things that I share with primary care providers when we do this training in primary care psychiatry training. And we use this AMPS model, AMPS, and we have the provider make sure we talk to the patient about certain things. And there are 4 things that are a must to ask when a patient's coming in, particularly if there's some issues already with depression or anxiety. And so this is a mnemonic where we look at the A stands for anxiety, right? And it's important to ask folks about anxiety because anxiety is common. Anxiety is really, really common. In fact, right now there's 65 of you listening to this talk. My best guess is probably 50 of you have some type of, you know, anxiety that's bothering you to some degree, particularly during this pandemic. And so best way to ask about anxiety is, hey, is anxiety or nervousness a problem for you? So if your doc's asking you that, just be kind of upfront, be kind of clear that anxiety is kind of bothering me, and you can describe what the anxiety is like. The other thing that we should be asking folks who come in to see us is asking about mood, right? So a couple of the screener questions that we ask to see if we're catching depression early, in the early stages so we can treat it, would be, the first question is down here in the blue box. Have you been feeling depressed or sad over the last couple of weeks? Pretty straightforward. The other question is, what do you like to do for fun? And have you been doing those things over the last couple of weeks, right? So you're asking about level of interest in doing things like hobbies, for example, and also you're asking about mood. Now, if either one of those questions are answered in a concerning way, then we go forward and we ask more and explore more and figure out if there's depression. But for all of you on the line, and even particularly for family and friends of people who may have been suffering for depression in particular, or even anxiety, asking them if they've been feeling sad or depressed the last couple of weeks, or asking them or seeing if they have diminished level of interest in things that they previously enjoyed is going to be important. Now, on the other side of the coin, a lot of folks can really look depressed and really seem, you know, pretty down and maybe crying and low interest in doing things. But they could have what we call a bipolar depression, which means they have mania, right? They have the opposite of depression some of the time or in the past, but right now they're feeling really depressed. And so the trick is to figure out if they've had a manic episode way back in the past. And again, a manic episode is really simple to understand. It's the opposite of depression. It's the opposite of someone feeling depressed. And we'll go into that in a second. But two quick screener questions that we as providers can ask folks is, have you ever felt the complete opposite of depressed, sort of abnormally happy, where friends and family were worried about you because you were too happy? And then the other question is, have you had a lot of energy running through your body? So much energy that because of that energy, you didn't need to sleep for days and days at a time. So asking those questions can be helpful. Asking about psychosis, which is sort of a misperception of things in life and that, you know, the patient may be experiencing. Do you ever hear things or see things other people don't hear or see? And then asking about the most common delusion or fixed false belief is a paranoid delusion. Asking if you had thoughts that people are trying to get you or follow you or hurt you or spy on you or anything like that. Substance abuse is, a big thing that we're dealing with, particularly during this pandemic. Asking about drugs is pretty straightforward. Use any cocaine, heroin, acid, speed, ecstasy, marijuana, synthetic marijuana, or prescription medications. And so asking those questions can really, really be helpful. And then alcohol. So alcohol is probably the most used and most misused substance in this country. So asking, a loved one, or knowing that a provider, may be asking one of your loved ones or someone struggling with anxiety or depression about alcohol use is going to be really, really important. So this is what we train our primary care docs to kind of to use to make sure that we're picking up depression and anxiety early. Now, what exactly is major depressive disorder? Well, major depressive disorder is when someone has a discrete episode of depression. A typical episode can last anywhere from 8 to 24 months. And it's basically someone feeling really depressed and having what we call anhedonia, or a low interest in pleasurable activities for a minimum period of 2 weeks, right? So if someone's feeling down for like 2 days, it's not a depressive episode. But if it lasts 2 weeks or longer, it is. And then in addition, a lot of these folks will have difficulties with sleep, difficulties with appetite. Appetite can either go up or down. What we call psychomotor agitation or retardation. A lot of times patients will be they'll move kind of slowly, they'll think kind of slowly, they'll feel depressed, maybe low energy, fatigued, feelings of self-blame, worthlessness, guilt, difficulty focusing and concentrating on things, and sometimes, unfortunately, even thoughts of suicide. And so those are some of the things that we look at in terms of whether or not someone has a major depressive disorder. And that's kind of how we diagnose it. Now, I always like these things called mnemonics, where we can remember all this stuff by something, something that's kind of goofy here. And so sometimes providers will use this mnemonic SIG E CAPS. So this guy's name is SIG, his middle initial is E, and his last name is CAPS. Again, it covers the exact same thing I just talked about. And these are the criteria, the diagnostic criteria, the things that we look for if someone is currently in a depressive episode. And again, those of you who are joining, we have now about 80 participants. So those of you who are joining, feel free to type in if you have any live questions, and I'll address them real quick here for you. PHQ-9, the Patient Health Questionnaire 9, is a questionnaire that we use mainly in the primary care setting. And the purpose of this questionnaire, and again, it's up here in the slides for all of you guys to see, because it's important. This is a scale that we use to hopefully prevent, early stage depression, and also quantify the level of depression. And you can see here the questions are very much related to what we just talked about in terms of diagnostic criteria. Number 9 is the most important question, asking the patient, do you have thoughts that you would be better off dead or hurting yourself in some way? And again, the answer is going to be a 0, 1, a 2, or a 3 based on the severity of the question. So that's a great way to figure out if someone has issues with depression. Now, we talked a little bit about mania, right? And so let's dive in a little bit deeper, right? Because the issue with mania is that it's not as common as depression. But if someone has ever in their life had a manic episode, and we'll talk about what that is in some detail in a second, then they're likely to be depressed in the future. And I know that's kind of confusing, but someone who's manic or someone who has what we call bipolar disorder is likely to have, one or more manic episodes, and in the future, one or more depressive episodes. So if someone's really, really depressed, then we need to figure out if they've had a manic episode in the past. And if they have, then the treatment's a little bit different for what we call a bipolar depression. It's different than what we would otherwise call just your more common unipolar depression as well. So that we're going to talk a little bit about this and kind of get an idea of what that's all about. Someone's asking, how can I help my son who's feels really depressed? What would you recommend to include in a workplace environment, a wellness program, support mental health in these times? Well, I think support groups are terrific. Being in close contact with family is important. And we're also going to talk about medications a little bit. Yeah, we're going to go into medications. And I want to talk to you about, because it's very likely that all of you, or almost all of you on the line here, are going to have some familiarity or questions about commonly used medications for both anxiety and depression. So we're going to go through those. What is the best way to help veterans who do not want to reach out for mental health counseling? That's a tough one. I would suggest going to your primary care provider and just kind of talking with them and seeing, what can be done. That's usually a good way to go. Sometimes people might feel more comfortable going to their primary care provider to talk about these issues. And so that's one thing to really, focus on. The other is to maybe look into, going to a VA hospital where there's special training and staff in that area, which can be really important. Any inpatient or outpatient suggestions for my 20-year-old stuck in severe depression? Remember, we talked about earlier, those folks who are in their 20s and 30s, some of them are really suffering during this COVID-19 pandemic. He does not use drugs or alcohol. He went to the wilderness and to a residential treatment facility when he was 16. So I think if someone's really struggling with depression, here's my answer. I think that you have to use a dual approach to treatment, a combo approach to treatment. So medications are going to be important, but also therapy or counseling or talk therapy is going to be important, right? So I know a lot of people think, oh, you're a psychiatrist, so you're going to prescribe medications. And I do sometimes, but it's also important to look at the whole person, not just part of the person or just part of the brain, and not just to focus on medications. A combination of medications with counseling is, no question, is definitely, absolutely the way to go for someone who has what we call moderate or severe depression or anxiety. So just giving a pill in that circumstance generally is not a good way to go. You want to use a combination approach. So if someone's manic, they're going to have sort of an expansive, elevated, sometimes irritable mood. They may be hospitalized, for at least a week in a psychiatric facility. You can see here on the screen, I won't go through all of these, but these are some of the criteria, the diagnostic criteria for someone having a manic episode. A manic episode usually lasts a week, maybe 2 weeks. They don't last months and months. If someone's having a manic episode for months and months, then something's a little off. There's something else going on, right? But sometimes these folks will be really grandiose and they won't really need sleep. They'll be kind of talkative more than usual. A lot of fast thoughts, and they may be distractible and really focused in on a goal that seems a bit, again, grandiose or out of the box. Excessive involvement in pleasurable activities and significant, dysfunction in dealing with life in general, particularly work and things like that. One of the questions is, how is medication for bipolar depression different than medication for depression? We're going to talk about that actually right now. This is a slide that looks at Prozac, right, as one of the antidepressants. Now, Prozac was the very first medication that came out in the 1980s that differentiated itself from the older antidepressants, the ones that have more side effects, right? And so Prozac is what we call an SSRI, or a serotonin-specific reuptake inhibitor. Fancy way of saying the serotonin um, level in the brain is normalized if you give an SSRI like Prozac. And so Prozac's been with us a long time. But I do want to talk a little bit about some of these medications and give you an idea sort of the different types of medications, right? And so here we're looking at these are SSRIs, right? And they're focusing on normalizing the level of serotonin, right? Then there's the SNRIs, which help normalize both serotonin and norepinephrine, both of those, right? Then there's mirtazapine, which has a different way in which it works, but it really affects the serotonin a little bit. And then bupropion, or also known as Wellbutrin, doesn't affect serotonin at all. Doesn't affect serotonin, so it's very different. But it affects the dopamine level and also the norepinephrine level. And then I was on a medication for 6 months for depression and anxiety. I stopped using because it felt better. But here and there I feel depressed. Should I continue taking the medication again? So here's the thing. Let's say someone has like one big bout of depression and then they have a second big bout of depression. Remember what I said earlier, the chance of having a third is about 85%. So I would talk to your doc about that, but really strongly consider an indefinite antidepressant and therapy, by the way, with the goal of you not getting another depressive episode, right? So that's the reason I might consider being on another medication at that point. Another question from Arlene is saying, my PCP told me flat out he does not deal with mental health and leaves it to psychiatrists. Ooh, okay. Well, let me comment on that. So I'm a primary care provider. I'm an internal medicine doc, and I can tell you that the job of a primary care provider is to work with the patient, work with you from a whole body standpoint. And guess what? This is part of the body, right? It's an important part of the body. So now on this side of the coin, a lot of primary care providers just got limited training in brain stuff, right? So they know a lot about the heart, they know a lot about asthma, they know a lot about ulcers in the stomach and gastritis, they know a lot about kidney failure, and they know a lot about hepatitis, liver problems. They probably know a lot about rashes and arthritis. They do. They know a lot about that, but oftentimes the training for mental health stuff was limited, very, very, very limited for PAs, MPs, family medicine docs, and internal medicine docs, oftentimes for pediatricians as well. So keep that in mind, and try and shop around for a PCP who can really help you across the board from head to toe. Again, one of the things that we do at University of California, Irvine, is we have a program called the Train New Trainers Primary Care Psychiatry Fellowship. So guess what? That means that we're training people like your doc, PCPs, how to do this stuff. We're training them how to diagnose, prevent depression, anxiety, psychosis, substance misuse, things like that. We're training them over a year on how to do that. So we're trying to expand this training in the state of California to make things better for people who are suffering from mental illness. Because here's the thing, people who have, in particular, severe mental illness are struggling. Life is not good. And in fact, these folks even have a much shorter lifespan, by as much as 20 to 30 years relative to people who don't have severe mental illness. One of the things I do in my career is I fight for those folks, because here's why. They're struggling. They're not really well represented or treated. They often get suboptimal care, medical care, preventive medical care, and psychiatric care, if any care at all. So I'm glad you asked that question. Looking for a PCP who can help you from head to toe is a good way to go if you can find it. CBD, we'll talk a little bit about that. That can be helpful sometimes. What about the concern of a person becoming addicted to the anti-anxiety depression medication? I've seen it with many people who seem worse off. So the antidepressants, right, that we're going to talk about don't have an addictive component. So there's not an addiction component. Now there are some antidepressants, some anxiety medications, and some pain medications actually that can have an addictive component, and that can kind of add a complex layer to what we're doing. But actually, all of the medications that we're going to be talking about today have no real addictive component. The question is from Fabiola, which is a great question. Is cognitive behavioral therapy the best way to treat depression and anxiety? Are you ready for the answer? This is the answer. Yes, it's one of the very best. And that's why we're going to talk about it today. We're going to learn. You guys are going to learn about cognitive behavioral therapy today. And so we're going to get to that. But it's a great, great way to go. In fact, it's been studied extensively for treating depression, for treating anxiety, fibromyalgia, irritable bowel syndrome, smoking problems, insomnia. It's a great tool. And I'm gonna connect you with it today, guys. You're gonna get a good idea of how to use it for the most part. My PCP told me flat out he does not deal with health issues. We talked about that a little bit. I've been a family doc for 35 years. Your doctor needs to find another career. Well, I would say yes. And I would say find a doc who can address you as a person and not a disease, right? Generally speaking, you don't want to go to a doc that's going to say, I'm just going to treat your hypertension. No, they're going to treat you. They're going to work with you. They're going to partner with you and not just treat a disease. So, and it looks like it says, the same doc is saying, this is Alan saying, by the way, after retiring, I took Dr. McCarron's fellowship in primary care psychiatry. Oh, good. Yeah. We got to deal with emotional issues because guess what? We're all emotional. We all have emotional issues. Every single one of us, right? Every one of us, every human. And so that's important to look at. So anyway, this is a quick overview, guys, on some of the what we call the classes of antidepressants. So we're going to go a little more in detail right now. Okay. Now, some people say, well, Dr. McCarron, why do you talk to non-doctors about this stuff? And I said, well, the reason I do that is because non-doctors, as well as doctors, by the way, but non-doctors also take these medications. Why shouldn't they know about these medications? They should know about these medications. So here we go. This is it. We're going to talk about some of the most commonly prescribed, most frequently used antidepressants, right? And so let's start off at the top. And all of these medications are SSRIs, which basically means, again, that we increase and optimize the serotonin level. That's really what it comes down to. And so Zoloft or sertraline is the first one. And these names are tricky because every one of them has two different names. And these are the doses here. But serotonin is a great medication. It's interesting because serotonin is unique because not only is it a serotonin, it increases your serotonin level, but it's the only SSRI that also optimizes the dopamine level. So it works in two different ways. The other thing that's nice about Zoloft is if you give it with other medications, you're taking it with other medications, the chance for interactions with other drugs is pretty low. It's pretty low. Then there's paroxetine or Paxil, which has been around for, 25, maybe almost 30 years. It's been around a long time. These are the doses. I don't use Paxil a whole lot, right? I don't use the Paxil a whole lot because there's a lot of side effects connected with it. It can make people sleepy. It can make them eat a lot, get dry mouth, sedation, things like that. And also it can have a lot of interactions with other drugs. And the other reason I don't use it a lot is because if you take it for several weeks or even months, and then you stop taking it for 2 or 3 days, or you forget it when you're on vacation and you stop taking it, unfortunately, patients can get sort of what we call a discontinuation syndrome. So they might feel not so good, kind of like light flu-like symptoms, kind of anxious, depressed, unfortunately, if stopping this medication abruptly. So I don't really generally use this medication. The other thing with this medication is you don't want to use it freely in women of childbearing age. It can have some what we call teratogenic effects. It can have some effects on the malformation of the heart. And so we stay away from that in those situations. Prozac, I talked about earlier, it's been around a long time. So we know the most about Prozac. Safe medication, stays in the blood system a long time. So guess what? If you skip a couple doses accidentally, you're going to be okay. It'll be fine. Luvox is a medication we don't use a whole lot, except if someone has obsessive compulsive disorder, which means a lot of anxiety because they want to maybe check locks or, things like that. So I won't go into depth there. Citalopram or Celexa and escitalopram and Lexapro are two commonly used antidepressants. Again, increase and optimize the serotonin level. These two medications have less chance for drug interactions with other drugs, and also they're safe. They're safe medications. All these medications, as I've noted, are safe on the heart, the kidney, the liver, the brain. So these are two medications that can be helpful. Now, these medications that I've just mentioned here and that on the slide can cause about 30 to 4%, 40% of the time what we call sexual dysfunction. Right? There could be temporary, right, or reversible issues with maybe a decreased drive in sex or interest in sex, or maybe issues with maintaining or getting an erection or ejaculating, things like that. And so if that happens, you just talk to your doc. You say, hey, this is what's happening. And then, you talk about options. But I want to stress, and this is really important, really, really important, is that those symptoms are reversible upon discontinuation or sometimes lowering of the medication. So that's important. I want you to keep that in mind. So that's it. These are the main medications, right, that we talk about that increase the serotonin level. We have a question saying, I have a relative who was molested by a caregiver when he was a child. He's now in his 30s and has social anxiety. He isolates himself, plays video games a lot, is quick to anger and self-medicates with cannabis. He's never sought counseling. He's vehemently against it. What can be done? Well, if someone wants to get help, then we want to get it for them. If they don't, we just keep offering it. It's kind of like, maybe it's a poor analogy, so my apologies, but if you have, I remember when my 4-year-old, he's like, I don't want to eat broccoli. I only want mac and cheese, for example, right? You keep offering, keep offering, and you're showing that person, in this case, that you care, right? That you care, and so just to keep offering is a good way to go. The other question you may want to ask is, why vehemently opposed to psychotherapy? What's the reason for it? You can say, it's okay. It's okay. I understand you're opposed to psychotherapy. I get it. But try and understand the reason behind it, because the reason behind it may be flawed, right? And so understanding that could be important. Rodney's asking about ketamine treatments. And, ketamine is kind of an up and coming approach to treatment of depression, and it's very different than the medications I'm going to be talking about here. We first started using ketamine for a treatment of depression for those who are really suicidal. We would give it intravenously, and then a lot of these patients would feel better, but the only problem is it was transient in nature, so patients wouldn't really feel better long after the shot, but they would feel better after the infusion. And then then came, compounded ketamine, pills, and then nasal spray. And so ketamine can be a good augmentation strategy. It can be a good additive to some of these other medications to help. The best treatment for depression by far is ECT. That's our electroconvulsive therapy. The problem with ECT, as many of you know, is you can have some side effects. You can have short-term memory loss. It'll come back, right? Some may have subtle long-term memory deficits. Headaches are a little bit common after, somewhat common after the procedure, but just for a couple hours. But it's very effective, and ECT is another approach that we're not really going to talk a lot about today, but for severe depression, that's really a good way to go. Fabiola is saying, how can I help him and support him? I was on medication for 6 months for depression and anxiety. I stopped using it because I felt better. But I continued. Should I continue taking the medication again? I've heard CBT is helping a lot with these symptoms. CBD is, it's not an approved medication. Again, I would say these medications that I'm talking about here, coupled with therapy, those two together is really the best way to go. There's no question about that. Someone else, Tori's asking, my nephew is 21 years old and has been in and out of jail and was diagnosed with PTSD. that's tough. That's tough. And, PTSD is difficult to treat, but it can be treated, and there's different ways to do it. But really focusing on the anxiety and therapy is really, really critically important for those who have post-traumatic stress disorder. And so again, this is another example, right? Because I know a lot of people probably think, oh my gosh, the psychiatrist is talking, so he's going to talk about medications. And I am talking about medications, but I'm also talking about using a whole body, a whole person approach, which more often than not should include some type of talk therapy. This can be really, really important. These are some other medications that we use commonly for the treatment of depression: Effexor or venlafaxine, venlafaxine or Pristiq, and duloxetine or Cymbalta. Now, these medications increase the norepinephrine level as well as the serotonin level. These medications are frequently used by primary care providers, not necessarily or exclusively for depression and anxiety, but guess what else for? They're used frequently for the treatment of pain, different types of pain disorders. So for example, if someone has really bad diabetes and over time the diabetes causes what we call neuropathic pain, which is sort of a shooting, sharp, burning sometimes sensation in the feet, the toes, these medications can sometimes be helpful. And so we use it for that kind of what we call neuropathic pain, but also certainly used for anxiety, and also for depression. So those are some other things that we use these medications for. Now, a couple quick things. If you have really bad high blood pressure, make sure to talk to your doc about it, because venlafaxine might not be the first choice. It can increase blood pressure a little bit. Cymbalta or duloxetine is a medication like Paxil that you don't want to miss, more than 2 or 3 days, because you could start feeling that discontinuation syndrome that we talked about earlier, kind of feeling flu-like symptom, not so good if you stop it, and then for a few days. So that's just something to keep in mind. A lot of these medications, if you want to come off of them, please partner with your provider. Again, you've heard me say this many times today. As opposed to just stopping, you go to your provider and say, listen, I don't want to be on this medication more. I want you to help me come off of it. Then it can be done safely over a matter of 1 or 2 weeks generally. And again, it's not because there's an addictive component, but you want to make sure that you're coming off of it in a way in which your body's like, oh, okay, I'm cool with this. This isn't so bad, Okay. And then we're going to talk a little bit about Wellbutrin. Now, Wellbutrin, again, is a medication that's very unique because it doesn't have that serotonin component. And in fact, Wellbutrin is a medication that we'll use for patients who sometimes are pretty depressed, but maybe they have some of that sexual dysfunction that we talked about earlier, because that sexual dysfunction is caused by one of the receptors, the what we call the 5-HT2A receptor, or the serotonergic subtype 2A receptor, that causes sexual dysfunction, or can cause sexual dysfunction, rarely, but it can. And bupropion doesn't even touch that receptor, so it's not an issue. Now, with bupropion, you want to be careful because you don't want to use this medication, and you don't want any of your friends or family on it if they have a history of having seizures, eating disorders, or really bad anxiety. This is the one medication that we've talked about so far that's really generally not the best for anxiety. It's strictly for depression. Also keep in mind that this medication can also be used for smoking cessation, to help people with nicotine dependence. So you don't want to take, bupropion and this smoking medication, Zyban, at the same time. You want to stay away from that if you can, because you're just giving double the medication, and that's generally not a good idea. But bupropion is a really safe, good medication for folks who are struggling with depression, actually. Fabio was asking, if you get panic attacks, what's the best medication to take? Well, it depends on the situation. Panic attacks can generally be, probably the best way is to start off with one of these medications here on the slide at a low dose. So you notice here, for example, Zoloft, I have start at 50 milligrams. I would start at 25, and then in a week or two, go to 50. So interestingly, you want to start low, go up slow, but probably go up higher for anxiety disorders like panic attack. So that would be my recommendation, is one of those medications. I would not use bupropion because that could potentially not help or even make it worse. And then the question is for those episodes specifically, here's the thing with panic attacks. Remember, panic attack can just boom, just come on out of nowhere. So you want to take a medication that's going to make the panic attack not come out of nowhere, right? What good is it really if you get a panic attack and then you take a pill and you wait for that pill to get rid of the panic attack? It doesn't help a whole lot, because your typical panic attack will peak at 10 minutes. So which means it only lasts 20, 30, 35 minutes. If you're having a panic attack that's lasting 5 hours or all day, guess what? You're not having a panic attack. It's something else. Something else is going on. So again, a panic attack is really short-lived. So taking a pill when you have a panic attack doesn't do much good, because the pill's not going to start to kick in for about 30 minutes. And we don't want you to suffer during that time period. Lisa is saying the problem is that there is no objective test for mental illness. Absolutely true. It's true. The doctor is relying on an unreliable source of information, so the doctor needs to be well trained in teasing out symptoms for the patient. Patients need to be honest with your doctor, and it's better to tell too much than not enough. Well, Lisa, I think next year I would like for you to help present with me. You're spot on all of that. In fact, let me take a segue. Lisa's right on target. Let me take a quick segue, if I can, and talk about the fact that psychiatric stuff is very different than heart stuff or liver stuff or kidney stuff. And I've studied all that stuff, right? I can tell you that we don't really know exactly what causes PTSD or depression or anxiety disorders or schizophrenia. We don't know. There's not a magic test, right? There's not an X-ray or a CT or an MRI, unlike a lot of other things that we can diagnose in general medicine. So it makes it a little more challenging, but if we work together, like Lisa's saying, we can get through it, right? We partner with each other. Remeron is another medication that we can use as well. Okay. So guess what? We're going to switch gears. We are going to switch gears and talk about cognitive behavioral therapy, because I think cognitive behavioral therapy is one of the most important therapies that we can learn. And again, I've had some people say, well, Dr. McCarron, why are you talking about how to use a therapy to non-providers? Well, here's why. Because non-providers, as well as providers, but non-providers use this therapy. So why shouldn't they know about it? They should know about it. And that's why we're talking about it. You're going to come in and you're going to see your doc, your family, your loved one is going to come in, and they're going to be complaining of depression or anxiety, and they're going to be upset. They're going to be feeling badly, right? Now, you can give an antidepressant here. You can affect, the brain with a medication, and that can certainly be the case. But more often than not, there's a middle piece here, right, that a lot of us don't think about. So the brain is causing depression or anxiety or really bad feelings or emotions. Well, in between the brain causing this over here is what we call dysfunctional thinking, thoughts that are dysfunctional. Now you might ask, what does that mean by dysfunctional? A dysfunctional thought is two components to it. One is it's inaccurate, and two is it's negative, right? But the most important component is that it's inaccurate. It's not true. So examples would be, no one likes me, everyone hates me, I'm no good, right? And these are common things that people who are depressed might be thinking. The problem is they're not true. A lot of times people, when they get depressed, they'll use this all or none thinking, like I just mentioned before, right? No one likes me, everyone hates me, I'm no good, I'll never amount to anything, no doctor listens to me, the physical therapy will never help, right? And so it's that all or none, right? All or none sort of dichotomous thinking that can be really, really dangerous and really make the depression worse. And so what we do with cognitive behavioral therapy is we teach folks who are struggling with depression or anxiety to pick up when they're feeling really badly. At the exact moment that they're feeling really badly, we ask them to pick up their own thoughts. What is it that's running through your head? What thoughts are running through your head? We ask them to pick that up, and we ask them to write it down. And then we ask them to say, is this true or false? And if it's false, we ask them to reconstruct the thought, rearrange the thought, reword the thought, so now it makes sense. And that's really what it comes down to. Alan is saying, I give all my depressed and anxious patients Feeling Good by David Burns and prescribe that they read the first 80 pages. Alan, I think we know each other. We must know each other, because I've been doing the same thing for about a quarter of a century, and I do the exact same thing. So Feeling Good is the book by David Burns, who's the author. And I have them read just the first 80 pages. Now, I have them read the first 80 pages because the book's like 400 pages. And the book was written back in the 80s. And the book has a bunch of information on antidepressants from the 1980s. We don't use those medications anymore. That's old stuff. So I have them read just the first 80 pages or so. And we call this bibliotherapy. And so even for you out there, you folks who are struggling with depression or anxiety, and again, I have no financial stake in this book, but it really is a good book. It's a good starter. The book Feeling Good by David Burns. I'm actually working on a book that's called Feeling Great. When I come out with that, I'll let you guys know. Okay, it's probably just a little bit better than Feeling Good, Feeling Great. But it's a wonderful book, and I think you feel free to recommend it to your loved ones who might be struggling with anxiety or depression. Okay, Allie liked my joke. Someone liked my joke. So cognitive behavioral therapy is a great way to go, no question about it. And I want you guys to read about it. There's a thing called a dysfunctional thought record that we use to help track those feelings and those thoughts and to reconstruct those thoughts. In fact, I often will refer to the 3 R's for folks who are struggling with depression or anxiety when it comes to cognitive behavioral therapy. And I am a cognitive behavioral therapist. I recommend this a lot. I teach this a lot, and I use this a lot with folks who I see. The first R in cognitive behavioral therapy is to recognize your dysfunctional thoughts. No, it's easy to recognize if you're feeling depressed. It's easy to recognize if you're feeling anxious. That's easy. It's almost like stubbing your toe. Do you ever stub your toe really, really hard, like where the nail comes off, right? You stub your toe. Have any of you ever said, I just stubbed my toe, I think, and my nail just came off and it's bleeding a little bit? No, you didn't do that. You probably said ouch or other words, and you knew that you stubbed your toe. There's no question you stubbed your toe. No question at all. You stubbed your toe. Ouch. Bad news. So when you have depression, you have anxiety, you know it. There's no question, right? But the question is, and what we don't really recognize are these hidden negative thoughts, dysfunctional, inaccurate thoughts, right? If you recognize those thoughts, that's when you can pull them out of your head and recognize them and flip them, change them, so they're no longer inaccurate. And you can, the second R is to reconstruct them, right? So first step is to recognize this is a wacky thought. It's not true. The second step is to take that thought, reword it, reconstruct it, reconfigure it, so it makes sense. So for example, I'm so upset, my doctors never listen to me, right? So if you stop and say, well, is that true, right? A lot of times patients will say, well, you know what? I would say half my doctors don't listen to me, but you know what? This doctor's listening to me. Okay, fine. One doctor's listening to me. Instead of saying, oh my gosh, no one's listening to me. No doctor's listening to me. The third R is to repeat. So you want to, in order for cognitive behavioral therapy to work, you want to recognize those dysfunctional thoughts, do the dysfunctional thought record, which is in the David Burns book, reconstruct that thought, and repeat it. And guess how long for? You want to repeat this for? Forever. Here's the beauty of cognitive behavioral therapy. Like other types of psychotherapy, it's a tool that you learn. It's a tool that you learn that you can use forever. That's it. And there's no copay and there's no side effects. So it's a great way to go. No question about it. Alan again is saying it takes prioritizing, but it would make his work level much more balanceable. I speak from experience. Many PCPs have therapists who work on site with them to deal with counseling part and do surveys periodically to track their progress. Okay, well, I'll tell you what, I know we've covered a lot. In a nutshell, here's what we did, guys. We talked about depression. How do you diagnose it? How do you prevent it? What is anxiety? We talked about how to treat depression and anxiety. We went over the medications, the most commonly used medications, and we went over some of those common side effects for those medications. We dove into cognitive behavioral therapy a little bit, and we're able to answer some questions. But there are many, many more questions that I've received. So I want to make sure to address those. And we have maybe 7 or 8 minutes. So I'm going to dive in right now. And here we go. Is coffee a contributing factor for depression? No, not that I'm aware of. Statistics show that anxiety and depression are on the rise. Why do you think it is? Statistics are correct. And there's a lot of evidence showing that in the last 6 months, depression and anxiety and substance misuse, as well as divorces, have increased. And I think the answer to the question is we are now, currently, it's happening. We are in a psychiatric pandemic. That's what's happening. Now, we're also in a infectious pandemic, right? We're dealing with the virus that's out there. But make no mistake about it, we are dealing with a psychiatric pandemic right now. What is the best way to help a spouse dealing with depression? Well, attending this lecture was a great start, right? Hopefully you got some of this information. Reading the book, Feeling Good. And notice I say whoever wrote the question should read the book Feeling Good, right? And also have your spouse read it as well. I often tell family members, please read this book, because then the book will help the family member support the person, the loved one, who's dealing with the depression. Everybody has anxiety. Why is mine considered clinical? I would say that all anxiety is non-clinical, or all depression is non-clinical. I don't really use the word clinical depression or clinical anxiety. When someone's depressed, when someone's suffering from anxiety or depression, that's just what I call it. They're suffering from anxiety or depression. More technically, there's no such thing as clinical depression or clinical anxiety when it comes to a formal diagnosis. So I consider everything clinical. If someone comes into my office and they're like, man, life sucks, I'm dealing with this and it's horrible, that's good enough for me. I don't differentiate between clinical and non-clinical. It's all important. When working with mood stabilizers, which is the one with the least side effects? Well, we didn't really talk about mood stabilizers today because we generally don't use them for either depression or anxiety. However, mood stabilizers can be used for the treatment of bipolar depression, among a few other diagnoses in the field of psychiatry. Examples of mood stabilizers would be lithium or Depakote or Tegretol. And then sometimes we could even use the antipsychotic medications to help stabilize the mood a little bit. I would say the one that has the least side effects or the least potential for badness might be Depakote. Although there are some side effects there, including weight gain, for example. What is the latest research saying about prevention? Prevention is important. The Annals of Internal Medicine just published a paper in June suggesting that females starting at the age of 13, I don't know why 13 is somewhat arbitrary, but at the age of 13, get screened for anxiety at intervals of time that were not decided upon or agreed upon. But the point is, prevention is all about partnering with your provider, right? That's what prevention is. And so screening, and there are different easy tools that we can use to screen for anxiety. We talked about the patient health questionnaire, the PHQ-9, screen for depression. So the research says that it's important. The U.S. Preventive Services Task Force strongly recommends that we do extensive screening in the primary care setting for depression. How can we address the cultural barriers with regard to anxiety and depression? I think we just need to be aware of them, and we need to teach. What these barriers look like. Unfortunately, a lot of providers out there just maybe they didn't get the training in cultural barriers or cultural humility. One of the things we're doing with our trainers primary care psychiatry fellowship is training PCPs on the basics on cultural humility and cultural considerations for people suffering from depression, anxiety, etc. How exactly do you treat anxiety and depression? We've gone into that. So we got that down. You guys are experts in that. What is the most effective medication? We talked about that too. We also talked about which medications you might want to stay away from, given the particular medical situation. So we went over that in some detail, which I hope was helpful. Again, a lot of people say, why do you do that? I think it's important. I think it's really important for us to do more training for people who are actually taking the medication and not necessarily prescribing it. I think it's really important. What is the best treatment for a rape survivor? Well, that is it's a great question, and any kind of trauma like that is so difficult, and it can really affect someone for a long time. I think getting involved in therapy, and oftentimes group supportive psychotherapy is important. Can give you the tools you need to deal with that kind of trauma. It's very difficult, very challenging. The other thing too is people who are survivors of a trauma like that can be struggling from depression and or anxiety, and treating that depression and anxiety also is important. Is paranoia usually a feature of anxiety or depression? Paranoia can be a feature of depression. In particular, if depression is really bad, then someone can have what we call psychotic features, where patients may be a little paranoid. Some of the times they might hallucinate. It's somewhat rare, but it can happen, and only in cases of really severe, pronounced depression. What are some coping skills to deal with daily anxiety and depression? And we've talked about some of those a little bit earlier. Again, using the book Feeling Good, Cognitive Behavioral Therapy can really be helpful. Of course, proper nutrition and sleep is going to be important as well. How can PEDS doctors become more educated about child development and mental health, to talk to parents and recognize signs? So this is one of the things that we train pediatricians as well in our Train New Trainers Primary Care Psychiatry Fellowship as well. What is the likelihood of anxiety and depression is becoming its own pandemic soon? Well, it's here. It's here. And again, I stress that, and I appreciate this question, because here's why. It's important for us to know that. It's really important for us to know that, so we can just be aware of it. We really need to be aware of it, and so we can help each other and really partner with our providers. Okay, a couple of really quick things that I want to mention. Do you think there's something in our environment that's causing more mental health disorders than years ago? Yes, I do. The answer to that question is, without any question, I think it's the COVID-19. Thank you for the information and understandable presentation. Oh, you're welcome. Depakote can add a lot of weight. Yes. If your depression or anxiety is trauma related, do you suggest EMDR? EMDR is something that can be helpful. It's a type of therapy that involves movement of the eyes. Can be very helpful with a skilled therapist, but sometimes that can actually temporarily increase anxiety a little bit as well. Yeah, and someone says all of this is important, especially during the social isolation period. That's right. Guys, we're also very isolated too, at work. I mean, it just with friends and family. It's really interesting. Can a patient be on one of these medications and still drink beer or wine? Or people tell me they think it's okay. I don't agree. Well, I wouldn't drink a lot of alcohol if you're feeling depressed or anxious, but on occasion, a glass with dinner or so should be fine, and there should not be a problem with interactions with the medications. But again, stressing not to drink excessively. I have a relative who was molested by a caregiver when he was a child. He's now in his 30s. Social anxiety, isolates himself, and I think we talked a little bit about that. So, yeah, but I know we just have a few more minutes, and I want to take just a couple more questions here, if that's okay. How does one help someone with anxiety and depression? Well, great question, and again, that was the reason we wanted to give this talk today. Gosh, we want to support each other. If you think about it, we're dealing with whatever you believe, whatever your religious, your political views, whatever they are. Here's the thing: right now in this world, we're just dealing with a lot of angst and a lot of suffering. A lot of political unrest, a lot of issues with this pandemic, I think supporting each other as best we can, understanding each other, empathizing with each other goes a long, long way. It really does. And we can all do that here on the line. So that's going to be really important. Are there any good medications to manage anxiety? What alternatives to medications to anxiety? We talked a lot about that as well. So remember, and again, I want to almost end with this. Here's the thing. Medications are critically important in the field of psychiatry, but as important with that is going to be talk therapy, connecting with someone who can help you deal with these issues by way of psychotherapy, and that's going to be really, really important. I would like to know about anger and depression. They often can go together. There's not an anger pill necessarily, but a therapist will try and figure out where the anger is coming from. Is it coming from frustration? Is it coming from depression, substance misuse? Where's that anger coming from? And that's one thing that we can look at to help us, figure out what's going on. Is anxiety best treated with medication or therapy? And the answer is yes. That's the answer. I'm so glad that I was able to give this talk to you guys, because I would say 90% of the questions were answered with the talk, which was what we wanted to do. I hope this is helpful. And again, really grateful, just truly grateful for you listening and participating with your questions, and wish all of you the very best until we see each other, hopefully in person, at the next NAMI conference. You guys have a great day. Thanks so much.